Hello. Today we will talk about neuromuscular junction disorders. First of all, if you want to learn how your muscles contract, let me explain the physiology. Normally, when an action potential arrives at the neuromuscular junction, the synthesized and stored acetylcholine is released and binds to acetylcholine receptors. The channels in the receptors open and the rapid entry of sodium causes depolarization in the end plate region of the muscle fiber. If depolarization is sufficient, it triggers muscle contraction. And this process is quickly terminated by acetylcholinesterase. The most common disease of the neuromuscular junction is myasthenia gravis, which literally means grave weakness. Myasthenia gravis is simply an autoimmune disease characterized by weakness and fatigue. The main cause of this weakness is autoantibodies against postsynaptic acetylcholine receptors. These antibodies activate the complement-mediated process that causes destruction of the receptors. The thymus has a role in this process as a possible source of antigen. In these patients, we see thymus abnormalities such as hyperplasia or tumors like thymomas. Some patients have antibodies direct against muscle-specific receptor tyrosine kinase on the surface of the muscle membrane. These are AChR seronegative patients. In the clinic, women are more affected than men. The main features are increased weakness and fatigue with repeated use. The distribution of muscle weakness often has a characteristic pattern. The lids and extraocular muscles are often affected, and diplopia and ptosis are common. Oropharyngeal muscle weakness causes dysarthria and dysphagia. Speech may be mushy and difficulty in swallowing, and palatal weakness may cause aspiration. Weakness in chewing occurs after prolonged exertion. In 85% of patients, the weakness becomes generalized, and these patients are generalized myasthenia gravis. If weakness remains restricted to the extraocular muscles, it is ocular myasthenia gravis. The limb weakness in MG is often proximal and asymmetric, and deep tendon reflexes are preserved. Respiratory muscles weakness are serious, leads respiratory failure, this life-threatening situation called myasthenic crisis. We can see some diseases and toxins in the differential diagnosis. In Lambert-Eaton syndrome, there are autoantibodies against presynaptic calcium channels that reduce the release of acetylcholine. And it is often associated with malignancy such as lung cancer. Some drugs, such as penicillamine, cause drug-induced myasthenia. Botulinum toxin inhibits the release of presynaptic acetylcholine. And some intracranial lesions can cause diplopia. The first step for diagnosis is taking history and physical examination. We may see some suspicious findings. We find a decremental response on the repetitive nerve stimulation test. We can detect blockage and jitter in single-fiber EMG. Anti-AChR and anti-MuSK antibodies can be detected in the laboratory. In the anticholinesterase test, edroponium or neostigmine inhibits acetylcholinesterase in the synaptic gap, resulting in increased interaction between acetylcholine and acetylcholine receptor. If there is improvement, the test is positive. There are 4 group therapies to treat myasthenia gravis. Inhibition of acetylcholinesterase to increase the amount of acetylcholine at the neuromuscular junction and symptomatic therapy. Immunotherapy with steroids, immunosuppressants, or immunomodulating drugs. Short-acting immunomodulation such as therapeutic plasma exchange or intravenous immunoglobulin. Surgical treatment thymectomy. There are some medications that should be avoided prior to treatment in myasthenia gravis as they exacerbate the risk. These drugs, neuromuscular blocking agents, antibiotics such as aminoglycosides and fluoroquinolones, magnesium sulfate, and penicillamine. A patient with generalized myasthenia gravis may develop a myasthenic crisis with infections. They should be vaccinated with an annual influenza vaccine. We commonly use the oral acetylcholinesterase inhibitor pyridostigmine in symptomatic treatment. MuSK-positive patients have a poor response to this treatment. Most patients with generalized myasthenia gravis require additional immunotherapy. Glucocorticoids, azathioprine, mycophenolate mofetil are widely used. There is a risk of thymoma in 10 to 15% of patients, and surgical resection is indicated in these patients. In the absence of thymoma, thymectomy is recommended for generalized myasthenia gravis anti-AChR positivity under 50 years of age. In acute exacerbations such as myasthenic crisis, pyridostigmine, therapeutic plasma exchange, intravenous immunoglobulin or glucocorticoids can be used depending on the severity. There are also some conditions that affect newborns and infants. Neonatal myasthenia gravis occurs in 10 to 20% of babies born to mothers with myasthenia gravis. Maternal antibodies transferred to the fetus are responsible for neonatal myasthenia. Symptoms of this disease at birth include weakness and hypotonia. Facial diplegia often occurs. Bulbar weakness is common and causes poor sucking and weak crying. Secretions and weakness of the respiratory muscles causes respiratory failure. Treatment of neonatal myasthenia is supportive. It is a temporary condition, and most newborns recover within a few weeks. Congenital myasthenic syndromes are rare causes of neuromuscular transmission failure. These patients do not have anti-AChR antibodies. These disorders are caused by genetic defects in the presynaptic, synaptic, or postsynaptic components of the neuromuscular junction. All of them are characterized by weakness. Bulbar and respiratory weakness are common. These syndromes have been associated with sudden death in infancy in severe cases. Hypermagnesemia may occur due to maternal administration of magnesium sulfate. High magnesium levels block calcium, causing the release of acetylcholine to fail presynaptically. The neurotoxin of Clostridium botulinum blocks presynaptic cholinergic transmission, affects skeletal and smooth muscles and the autonomic system. Foodborne cases are common and cause infant botulism. In summary, myasthenia gravis is the most common disease of neuromuscular transmission and is an autoimmune disease. Antibodies to acetylcholine receptors have a role in the pathogenesis. Characteristic weakness and fatigue are common features of the disease. Extraocular muscles, limbs, and even respiratory muscles may be affected. Nerve stimulation tests, EMG, edrophonium test, antibody detection are important for diagnosis. Pyridostigmine, corticosteroids, immunosuppressants, intravenous immunoglobulin, and plasmapheresis are used in the treatment.